that is looking at the rates of people living with HIV infection by the year end 2017. And just wanted to show that so you can look and see where you are at on the map and get an idea of the HIV infection rates in your area. When we're looking at HIV diagnoses by race and ethnicity, this is really alarming considering the, where we all work, that American Indians and Alaska Natives have a higher rate of diagnosis than any other race or ethnicity. And we're not exactly sure why that is, but have some ideas. Another reason this is really important in our population is that, unfortunately, survival after stage 3 or later diagnosis of HIV, which would be considered AIDS at that point, survival is lowest in American Indian and Alaska Natives. One principle that it's really important we understand before moving on and talking about PrEP is the U equals U. And I know you guys are all familiar with this, but undetectable for HIV virus in the blood means that that person is untransmissible. And so when we're thinking about the cascade of care or the care continuum for HIV in the US, knowing that if someone is virally suppressed, they can't give HIV to someone else, really makes these statistics a little bit more, it makes it mean more, right? Because if you look at, let's look at just the American Indian, Alaska Natives, which are very comparable to all of the other races and ethnicities listed here. But if we have 82% of HIV positive people are diagnosed and 60% are receiving care, that matches up pretty well. 46% are retained in care, but only about 50% of those 46% that are in care are virally suppressed, which means that not only are we worried about these who are the missing from 100% who don't know that they're infected and are infecting others with HIV, but also the 50% here that know they're infected, that have been in care at some point, but they're not virally suppressed. So although we don't see tons of HIV in our area, we do know that there are people out there who have it that don't know it, and then people who have it and know it and aren't suppressed, and so could be sharing it, which makes PrEP even more important. One thing we teach our providers in Cherokee Nation when we're talking about PrEP, for some reason, I think people look at PrEP very similar to how some look at needle and syringe services, which we all know on this call that needle and syringe services are extremely important and a great prevention tool for infections. And PrEP is also, but some people don't have the same beliefs, or they don't believe science and scientific proven medical treatments. So many times that same thing, why would you give someone who's going to use drugs clean needles? It's enabling them. We get that question, unfortunately. And why would you give PrEP to someone who is knowingly exposing themselves to HIV? Unfortunately, we get that question too. And so I always try to make it very clear that PrEP is just a tool that we use in our big picture of HIV prevention. Sexual behavior modification, condom use, we test and treat for STIs, we can use PrEP and we can use PEP. For the same reason that you would give a healthcare worker PEP, we also give PrEP. And And so I think that, in the big picture, when we're talking about PrEP, we're really talking about all of these things, HIV prevention. So as you heard today, we recommended PrEP for the young lady who has hepatitis C, who maybe is at risk for getting HIV as well through intravenous drug use. And although this is a hepatitis C echo, in that recommendation, we understand that some people may not know exactly what PrEP is and how to provide PrEP for their patients. So PrEP is when people who are at high risk are given a medication, which is either Truvada or Descovy. It's taken one time a day to prevent a person who is exposed to HIV from getting HIV. PrEP is extremely effective. Just recently, the CDC came out with these statistics for PrEP when it's taken daily or consistently. And they define consistently as 4 days per week, which is amazing to me that you could take it just 4 days a week and it would still have great effectiveness, although I would not tell patients that. They need to take it every day. But 99% effective in preventing HIV acquisition and MSM, and between 74 to 84% among people who inject drugs. So very effective tool that we have to prevent HIV. What I listed here are the federal guidelines for PrEP and who should be offered PrEP. And you can see the main bullets. I'm not going to read each of these, but typically we think of MSM, and it's not just that. I think 26% of new HIV acquisition is in heterosexual females. So we need to make sure that anyone who has sexual risk factors, men, women, anyone gets offered PrEP if they would qualify. PrEP is also, as we mentioned, for people who inject drugs. And if someone has had repeated exposure in a post-exposure prophylaxis need, then they also should be considered for PrEP instead of doing multiple courses of PEP. So for primary care providers who maybe are not PrEP minded 100% of the time, considering PrEP when you discover that you have an at-risk individual would be the main thing that you could help with, right? Recognizing the need for PrEP, and that means to be asking about injection drug use, to be taking a good sexual health history and finding at-risk individuals, talking with the patient about PrEP, just knowing that PrEP exists and that PrEP could be easily offered to the patient if that was something that you would be willing to do. Sometimes it's easier than others to decide how to talk to a patient about PrEP or to ask about their sexual history. That can be difficult. That conversation is sometimes harder for some than others, but offering brochures for PrEP in your office is one way to help with that. Asking patients, did you read the PrEP brochure? Do you feel like this is something you might be interested in? Is it something that you need? And then deciding based on those conversations, is this something I'm going to offer my patient, or is this something that I need to refer out? And there are those providers, I'm sure, in your local areas. The CDC has a PrEP finder, PrEP provider finder tool that you can use and get that person to a PrEP provider if you're not wanting to do that yourself. We have a pharmacy program for PrEP, very similar to our hepatitis C pharmacists who are treating hepatitis C. And if you guys are interested in more information about PrEP or PrEP training or implementing PrEP in your Hep C practice, we would be happy to go into more detail about that. So I will stop sharing and turn it over to you, Brian, if there's any questions.
Great presentation. Thank you so much. Do we have any questions about PrEP for Whitney?
I have a question. Can I ask a question?
Yes.
Okay. It's about PEP. PEP's like an emergency, like day after, right? Is it that easy? Like, can you get that from a pharmacy, or how do you get access to that?
So PEP is for post-exposure prophylaxis. So we would give that for, like if someone presented to the emergency department and said that they were a victim of sexual assault, or if you have a healthcare worker who got a needle stick, that would be a potential candidate for PEP. So it's not like, it's not an over-the-counter. It has to be prescribed by the provider. You can't just present to a pharmacy and request it. Typically, emergency rooms or occupational health nurses are the ones who implement that PEP process, but it most often the emergency room after an exposure.
One thing about Whitney there is, and maybe you mentioned it, is or it doesn't have to be a sexual assault. It could be just a mishap on your sexual activity.
Right, yeah, good point, yes.
Your condom broke or...
Right, yeah, good point. Dr. Brown asked about the cost, and that's a really good question. So just last year came the, with the ending the HIV epidemic, came a program offered by Gilead and in conjunction with the CDC for something called Ready, Set, PrEP. And what that is, it gives access to anyone in the US who wants to be on PrEP to have access to those medications for free. So it is a really great program, super easy to get signed up. And if you sign up as a provider for PrEP, you can, basically my nurse like logs in for me and is an authorized user on my account, says I have a patient, puts in the patient's information, they get the approval within a matter of hours, and sometimes it's immediate, like they just say, okay, here's your access code, turn this in. There's several pharmacies that participate, and the patient can go pick up the medication from that pharmacy for free. It's called Ready, Set, PrEP, if you want to look it up. And I was just looking for the website. I'll send it to you guys in the chat. Oh, here it is. It's called so the website is getyourprep.com. And that's where you go to sign up as a provider. And the other way to do it is to have the patient sign up through getyourprep.com, but you end up having to fill out a paper prescription, and it ends up being more work for the provider. So my recommendation would be just you get signed up, and then you can sign up your patient with just a few clicks.
Thank you. Any other questions?
So I have one more for Whitney regarding that Ready, Set, PrEP. So, but if you have Medicaid, Medicare, or private insurance, how does that work, Whitney?
So for those that are insured, we haven't come across an insurance yet that didn't pay for PrEP medication fully. So insurers, including Medicaid and most Medicare Part D programs and private insurance, you can get your Truvada or Descovy for very minimal copay or no copay.
Thank you.
And you mentioned that Descovy was not for women.
Correct. So Up until probably 6 months ago, or 6 to 9 months ago, we only had one medication to use for PrEP, which is called Truvada. And the Descovy is a very similar form of medication, but it, instead of tenofovir diproxil, whatever, it's tenofovir alafenamide. It's better tolerated in the long term for bone health and kidney health, but it has not been well studied in women. It was only studied in MSMs who were on PrEP. And so although it probably works for women, we just can't say that for sure. So we only use that if the only risk factor is anal sex. And so if someone is injecting drugs and they're MSM, we would still need to use Truvada. Does that make sense?
Yeah, so the easy way to remember it is if you inject drugs or if you have a vagina, you cannot use Descovy, because transgender women can use Descovy.
Any other questions?
The only other thing I will add, Brian, is that I didn't mention this on my slides, but when I first heard of PrEP, some of you maybe have heard me say this, and if so, I'm sorry, because it's a horrible joke. But it's not a joke, it's true. But when I first heard of PrEP, it was from a patient who I was seeing for HIV. He was HIV positive, and we were talking, and he was like, "So I have a question. Can I get PrEP for my partner?" And I was thinking, like, I was trying to think of what that meant, because I never heard of HIV PrEP, which shows my level of ignorance, and that's fine. I mean, we all learn every day, but it was probably six years ago, and I was thinking, why? Because the only PrEP I could think of was colonoscopy PrEP. And I was like, why in the world would he want his partner to have PrEP? And then I was like, well, maybe, I mean, I'm just like so out of it, and maybe that's a thing. I don't know. So he's like, wait, you don't know what PrEP is? I'm like, no, you're gonna have to tell me. So he told me, and I thought, okay, yes, I can do this. Like, of course, I want to prevent your partner from getting HIV. And so sure. So that's where my journey with PrEP started. And then the other thing that I want to point out is that if someone presents to your office requesting PrEP, and as long as they understand what PrEP is, that it's a medication, that you take it to prevent HIV, that it does have some side effects, and you go through all of that, even if they are unwilling to discuss the reasons why they need PrEP or why they are wanting PrEP, they should still be given PrEP. So some people may request PrEP, but may not be willing to discuss why. And that's something that I think, eventually I would work on that patient with, like, let's talk about your risks and what else can I help you with? Where else can we go with this that could help you be safer? But as long as they understand why they're asking for PrEP and that they really do need it, then you should give it to them, because we have to trust the patient's judgment in that way.